So today I'm going to give a talk basically on fat grafting, titled Fat Grafting to the Breast, A Personal Journey Through an Oncoplastic Frontier. No disclaimers, no disclosures, although I will say I am post-call today, and people who know me well know that I have a tendency to butcher pronunciation, so I apologize for any names that I may mess up in advance. So, what are our objectives today? One, I want to introduce myself, where I started, where I plan to go, and what my plans are. We're going to discuss the literature and trends as it relates to autologous fat grafting to the breast. We're going to describe my journey of becoming a self-proclaimed expert in the field of oncoplastic fat grafting to the breast. And we're going to discuss my team's research and publications and how it will impact the future of fat grafting going forward. So a little bit about myself. I was born in New Orleans, or as we call it, NOLA. Spent most of my childhood in the bayou fishing and hunting. I left and went to Georgia, where I got a Bachelor of Science degree in genetics. Returned home to do medical school at Louisiana State in New Orleans. I spent my intern year in general surgery in Mobile, Alabama, at the University of South Alabama, where I had the fortune to upgrade and find myself at the University of California, Davis, where I did my 2nd through 6th year of general surgery training, including a year in the lab with Dr. Sahar. Last May, I matched into the independent plastic surgery residency, where I'll have the opportunity to master the art and continue on my journey of restorative and transformative power of plastic surgery. So what is oncoplastic surgery? Oncoplastic surgery really began in France in the 1980s. However, the term was originally coined by a German by the name of Werner Ostrich, maybe? So basically, how did this come about? In the 70s, mastectomy was a standard of care for breast cancer surgery. As women equal rights became more prominent, and women started to voice their opinion, and they really started to express the emotional and psychological stressors associated with having deformity of the breast, we started to look for better options. As our screening technologies got better, we were able to identify cancers at an earlier stage, and we started to offer breast-conserving therapy in the 80s. However, it was still estimated that approximately 30% of women who underwent breast-conserving therapy were still suffering from cosmetic deformities. Specifically, once your seroma absorbed and the radiation effects took their course, women were left with dimpling, disfigurement, protrusion of the nipple, and things of that nature. So we really wanted to look and focus on an emphasis of how can we offer a good cosmetic outcome without actually affecting the oncologic surgery itself. So why do we want to do oncoplastic surgery? The breast is a unique feature to the woman. It's something that can offer them self-identity. It's a source of their sensuality, a sense of their femininity. And they're well documented within the literature and interviews of women that there are psychological stressors associated with breast deformity. It can impede healing, it can impact relationships, but more importantly, it can alter self-esteem. Think about this. 1 in 8 women will suffer from breast cancer. We look around this room here, there may be 60, 70 women in here. That's saying 7, 8 women in this room alone are going to suffer from this awful disease. This is a common thing, and we need to have good sources to fix this. Estimated in America alone, in the year 2017, there will be 252,710 diagnoses of invasive breast cancer in women alone, an additional 63,410 diagnoses of carcinoma in situ. While the American Society of Plastic Surgery estimates that approximately 30% of women are told reconstructive options prior to surgery, that means over 150,000 women will undergo surgery for breast cancer without being told or having an informed discussion of their reconstructive options. So who and how can we do the oncoplastic surgery? This isn't just something related to plastic surgeons alone. This is something that breast surgeons and general surgeons can be doing themselves. There are a number of courses offered throughout the various fields that will teach and train surgeons how to perform oncoplastic surgery. The American Society of Breast Surgeons offers a course, the American College of Surgeons offers a course, but probably the most well-known course is the School of Oncoplastic Surgery. They basically break it down into 4 levels. They say that level 1 and basic level 2 can be performed by the general surgeon, while complex level 2, level 3, and level 4 should be done in conjunction with the oncology surgeon as well as the plastic surgeon. This course offers things focusing on preoperative breast markings, tissue transfers. They have a clay sculpting course that can look at the effects of doing lumpectomy on the breast. And the most important thing about this course, which makes it so unique, is they do they have a cadaveric lab, which allows the surgeon to get hands-on experience, which from the testimonies of various surgeons that have attended the course seems to be the most helpful. This is a 2016 statistics from the American Society of Plastic Surgery. I have highlighted an area of breast reconstruction. Between 2015 and 2016, there's been a 3% increase in the number of breast reconstructive operations performed by board-certified plastic surgeons that are a member of the American Society of Plastic Surgeons. If you look at this data from 2000 to 2016, there's been a 39% increase in the number of breast reconstructive surgeries performed by members of the American Society of Plastic Surgery. So what are your breast reconstructive options? Not every breast cancer is the same. Large cancers and invasive cancers will often require mastectomy. So there are things like tissue expander and implant-based reconstruction, rotational and free flaps, including the transrectus abdominis flap and the deep inferior epigastric perforator flaps. But autologous fat grafting is going to be the focus of our talk today. There's a wide range of volume. You can inject as little or as much fat as you want to harvest. It's less invasive. There's faster recovery. It can often be done on an outpatient procedure. You don't need extensive training in microsurgical expertise that you would need to perform a free flap. You don't need hospitalization that you would need to monitor a free flap. And the 2-for-1 concept, that being that not only are you offering the patient a reconstructive procedure, but you're also performing liposuction. So maybe they're getting a little mommy makeover or some sculpting or molding that they want. Here, I wanted to focus on just the soft tissue fillers. If you look at fat, from 2000 to 2016, there's been a 21% increase in the amount of fat that's been used to inject as a filler. But just from 15 to 16, a 13% increase. This is becoming a major component of the armamentarium of the plastic surgeon. Now, this data is not limited to fat grafting of the breast alone. This includes fat grafting for scar revision, fat grafting to the face, and things of that nature. But just the fact that fat grafting is becoming more and more popular shows a definite need to discuss what the options are and what the safety and efficacy of fat grafting to the breast is. So let's talk history. In 1987, the American Society of Plastic Surgeons banned autologous fat grafting to the breast over concerns of fat necrosis and the potential to interfere with the detection of recurrence with the current radiographic studies at the time. In 2007, the Society revisited fat grafting of the breast, determining that it may be useful and it may be safe, but the results were still unpredictable. In 2009, a fat graft task force was formed where a number of surgeons from throughout the world were brought together to review the literature and come up with new guidelines. At this point, they lifted the ban. In 2011, the American Society of Plastic Surgeons, as well as the American Society of Aesthetic Plastic Surgeons, joined together and created a joint task force. However, they still caution surgeons in performing stem cell-based breast augmentation because we just don't have enough information. In 2014, the FDA published guidelines specifically relating to this topic. Interestingly, in December 2014, these guidelines came out, what they call the HCTP, which stands for Human Cell, Tissue, and Cellular and Tissue-Based Products. Under these guidelines, there were basically 4 criteria that needed to be met for adipose tissue in order to be used. One of those was minimal manipulation. One was that it had to be a homologous use. Another was that you could not combine these cells with tissues or other articles except for water, crystalloids, or sterilizing, preserving, or storing agents, provided that this would not alter the metabolic activity of the fat. In addition to this, the adipose tissue could not have a systemic effect on the area it was being transferred to. In essence, this would make autologous fat grafting prohibited. However, in this article, there was a specific exemption that defined, basically it seemed to speak specifically to this one procedure. They said that as long as the tissue was harvested from and implanted in the same patient at the same procedure, you could do it, and it could allow minimal processing. When they define minimal processing, they specifically define centrifusing the tissue to remove the plasma and plasma section so that you are left with just your fat graft, which is basically the Coleman technique, which was one of the pioneers who started doing the fat grafting. So in essence, the FDA set regulations that would make fat grafting prohibited. However, they made an exception that basically freed it from this exemption, or freed it from this regulation so that we could continue to do it. So how do you make yourself a self-proclaimed expert in a field when you walk into a field that you know something about but not a ton? I did a literature review and ended up publishing a literature review in the Annals of Plastic Surgery where I looked at every single paper published on fat grafting to the breast and cancer recurrence between 2010 and 2014. I literally read 239 articles. I narrowed these down to 63 articles that specifically dealt with only breast cancer recurrence and fat grafting to the breast, or basic science studies that looked at the interaction between adipose-derived stem cells and breast cancer cells. Once I narrowed these results by excluding any reviews, case studies, or clinical papers that had less than 25 patients, I was left with 16 clinical studies and 9 basic science studies. So what did I learn? I learned that one study showed that as few as 5 breast cancer cells, when co-injected with mesenchymal stem cells, would result in breast cancer growth. If you look on this graph here, you can see down here the number of breast cancer cells that were injected in a murine model. With 5 or 10 breast cancer cells injected, when the presence of mesenchymal stem cells were injected, there was breast cancer growth. When those mesenchymal cells were not injected, there was no breast cancer growth in these murine models. However, when the number of breast cancer cells went to a large number, like 100, the presence of mesenchymal stem cells did not really affect. There was tumor growth regardless of whether or not there was the addition. So they basically said that they concluded that there is some effect of mesenchymal stem cells on breast cancer cells in a co-injection model and a murine model. So next, another group in 2010 showed that there was direct communication between adipose-derived stem cells and breast cancer cells. They set up a pretty unique model where they took a co-culture model and they plated breast cancer cells in the presence of adipose-derived stem cells, but they were specifically looking at the platelet-derived growth factor receptor. And there are 2 subunits, the alpha and beta. So what they did was plated them together, and they saw that breast cancer cells had increased migration when plated with adipose-derived stem cells. They then placed an antibody for the beta subunit and the alpha subunit independently and plated these. And they found that when they placed an antibody to the beta subunit, there was no migration of the breast cancer cells when compared to either blocking the alpha subunit or no blocking. They also ran gel electrophoresis and showed that the platelet-derived growth factor beta only existed in human adipose-derived stem cells, but was not a receptor found in the breast cancer lines they used, which were the 4T1 or the MDA MB231, which are the most common immortalized cell lines used to date in the basic science literature. So they concluded that there was direct communication between the adipose-derived stem cell and the breast cancer cell, and they proposed that this talk was somehow associated with the platelet-derived growth factor receptor beta subunit. Another study published in 2011 took patients that had metastatic breast cancer to the lung. They took pleural fluid and isolated breast cancer cells from this. And then they showed that adipose-derived stem cells would indirectly increase breast cell cancer proliferation when they looked specifically at these metastatic isolates. And then they isolated the adipose-derived stem cells and looked at a number of different cytokines and growth factors that they were secreting. And so they basically concluded that some of these growth factors are somehow either directly or indirectly affecting the proliferation of breast cancer cells. So we know that there are secretion of growth factors at this point, and we know that adipose-derived stem cells increase proliferation of breast cancer cells. So then we have to kind of define this a little bit more. There were 2 concurrent studies that were published in 2013 that looked at progenitor cells isolated from adipose tissue, and they basically said that they play a role in increased cancer recurrence. Endothelial progenitor cells generate mature endothelial cells and capillaries. These are important aspects to angiogenesis. The cancer-promoting effects in the breast were limited in the absence of adipose-derived stem cells. Both of these studies independently concluded that adipose-derived stem cells are more efficient at promoting tumor growth in the breast, and that adipose-derived stem cells and progenitor cells cooperate in tumor growth and metastases, likely through angiogenesis. They also looked at the VEGF expression and showed that there was upregulated VEGF when adipose-derived stem cells were in proximity to cancer cells, which would make sense with the concept of increased metastatic potential and increased capillary and blood vessel growth. This was a really interesting and awesome study that was done in 2014, and this was actually the scaffold for which I used to build my studies that we did. However, we made them much better. So what they did was they co-cultured adipose-derived stem cells in the presence of breast cancer cells, and they wanted to look at migration in a co-culture assay where they basically plated the breast cancer cells on a semi-permeable membrane in a well and then plated the adipose-derived stem cells below that and looked at the migration through the permeable membrane. And then they also injected adipose-derived stem cells and breast cancer cells into the mammary fat pads of nude mice, and they followed these for tumor growth, but they also harvested first-pass organs, specifically the liver, spleen, and lung, looking for micrometastases. And they found that, and if you look in this chart here, you can see that when there was a co-injection of adipose-derived stem cells and breast cancer cells, there was significant growth of tumor cells in distant organs, specifically a statistically significant increase in metastatic disease in the liver, lung, and the spleen. And you can see the green fluorescent protein cancer cells staining in the pictures below. They also measured VEGF in this study and showed that it was increased with the co-injection of adipose-derived stem cells. And again, they said that adipose-derived stem cells promote angiogenesis, which thereby could potentially increase the metastatic potential. Another study that was published in 2014 showed that adipose-derived stem cells and breast cancer cells make direct contact. They showed that there were morphological changes that existed when adipose stem cells were plated in proximity to breast cancer cells. They created these spheroids. They even showed foot-like projections coming off of the adipose-derived stem cell and physically making contact with the breast cancer cell. They then measured the transcription genes for many typical malignancy markers. And if you look in this chart here, you can see that every single gene marker that they looked at had upregulation when compared to the cancer cell alone and the cancer cell culture with adipose-derived stem cells. Now, it is possible that you had a cumulative effect of secretion from the adipose-derived stem cell and the cancer cell giving you this increased expression. But if you look at the second marker that they looked at with this large bar here, independently, the adipose-derived stem cell and breast cancer cells showed no expression of this gene. However, when they were co-cultured, there was significant increase in gene expression. The authors concluded that not only do the cells make direct contact and have morphological changes, but the adipose-derived stem cell is specifically aiding the breast cancer cell in increasing gene transcription and regulation. There's another study, which is pretty complex and a difficult study that I could spend an entire lecture just going through. But to break it down, basically, they looked at breast cancer cells and they looked at fat that was harvested from patients. And they found a direct correlation between c-Met expression on breast cancer cells and the susceptibility of tumorigenesis promoting effects on adipose-derived stem cells. They showed that there was increased tumorigenesis when there was increased expression of hepatocyte growth factor, and that donors that had increased c-Met expression in breast cancer cells were more likely to develop recurrence following fat grafting in a clinical setting than those that did not have it upregulated expression. And so they concluded that there is some master role between hepatocyte growth factor and c-Met crosstalk in the tumorigenesis, and specifically the role between adipose-derived stem cells and breast cancer. However, they weren't adequately able to define a pathway. The last basic science study that kind of devolves into this topic is another one that was published in 2014, and it again looks at upregulation of gene expression, except instead of looking at the gene expression within the breast cancer cell, they looked at the gene expression within the adipose tissue itself. And they wanted to know, is adipose tissue affected by the breast cancer cell? Because everybody's talking about adipose tissue affecting the breast cancer cell. And so what they did was they developed a model where they measured 10 separate genes, and they wanted to look at the expression of these genes, and they took adipose tissue surrounding breast cancer. Then they took adipose tissue distant from in a distant area, but in a patient that had breast cancer. And then they harvested adipose tissue in patients that had no cancer. And you can see that the blue diamonds are patients that had adipose adjacent tissue adjacent to tumor, and there was the highest regulation. And then patients that had cancer but they took tissue distant had the middle level of expression, and then in patients that didn't have malignancy, they had the lowest levels of expression. And they basically concluded that inflammation, proliferation, invasion, and migration genes are all upregulated when cancer is present in adipose tissue. And the previous concept that adipose tissue is just an inert fat that's there is wrong, and that it's actually an active endocrine organ that is involved in a complex relationship with cancer and tumorigenesis. So what do we conclude from this research, this literature review? That adipose stem cells and breast cancer cells communicate, they make direct contact, that adipose stem cells will directly increase migration and proliferation of breast cancer cells in a co-culture model, and that you get increased gene expression of typical malignancy markers when adipose stem cells are plated in close proximity to breast cancer cells. We also found that adipose-derived stem cells and adipose tissue is not inert, but is an active endocrine organ. In addition to this, in mirroring models, increased primary tumor size and increased metastases, specifically at first-pass organs like the liver, spleen, and lung, are reproducible in the literature. So then clinical data. There were 16 clinical studies, and I'll go through some of the basics of these. I know this is a busy slide and hard to understand. The things I want to point out is that most of the patients were in their late 40s or early 50s in these studies. The number of patients ranged from as few as 28 to as many as 513. But the big thing is the cancer operations weren't standardized and the stage of cancer study wasn't standardized. You look at some of these studies that have 0% recurrence, like this one, and they only looked at T2 or less lesions. Well, T2 less lesions are going to be less aggressive tumors, and so the likelihood of having recurrence from a less aggressive cancer makes sense. So this is the reference slide for these. So the clinical data. In total, there were 6 trials that showed no local recurrence. The number of patients studied ranged from 28 to 151, and these had to have a minimum follow-up of 1 year. There were 3 prospective trials in total done. The first one had a sample population of 158. There was local recurrence in 1, or 0.6%, and an average follow-up of 18 months. Another had 67 patients, but only followed the patients for 12 months, and there was no local recurrence. And the last had 59 patients that showed local recurrence in 3, or 5.1%, with an average follow-up of 34 months. It makes sense that the longer you follow the patient, the more likely you are to capture a local recurrence. However, these numbers do fall in line with patients that have breast cancer recurrence that don't undergo reconstructive or fat grafting procedures. Probably the single most important scientific contributor to the clinical data of breast cancer recurrence following fat grafting is a surgeon scientist by the name of Petit, one of the two. Basically, he first started a multi-center study that encompassed Milan, Paris, and Lyon. He looked at 513 patients that underwent fat grafting following mastectomy or breast-conserving therapy, and he included in situ as well invasive carcinoma. So basically, he captured every patient that could be a potential candidate for breast autologous fat grafting to the breast. And he found that there was a local recurrence of 2.4% or 1.5% per year and a distal recurrence of 3.1% or 1.9% per year. This fell in line with the average numbers of breast cancer recurrence that didn't undergo fat grafting or reconstructive procedures. In 2012, he did a prospective study where he followed 321 consecutive patients and matched them to a 1 to 2 cohort with similar demographics. He found the local recurrence was 8 or 2.5% compared to 19 or 3%. No statistically significant difference. However, he did notice something interesting. When he looked at a subset analysis of 39 patients with just intraepithelial neoplasia, he found that the local recurrence of 4 or 10.8% compared to 0 in the matched cohort. So this got his team thinking. This is interesting. This is basically the first time in the clinical data we have been able to publish data that shows that there may be a risk of clinical recurrence in certain types of cancer. So in 2013, he followed 59 patients that specifically had intraepithelial neoplasia who underwent autologous fat grafting to the breast and matched it to a 1 to 3 cohort. And he found an 18% 5-year cumulative risk of breast cancer recurrence in these patients compared to a 3% in the patients in the cohort study. Now granted, this is only 59 patients. We're not going to make any practice-changing conclusions from this data, but this is, to date, the only clinical study that has shown a statistically significant increase in breast cancer recurrence following autologous fat grafting. So in total, 2,100 patients throughout these studies with a local recurrence in 47, which is an average of 2.2%, with a follow-up anywhere from 1 year to 91 months. So what did we learn? There is a distinct discordance between basic science studies and clinical data. Clinical studies have failed to show an increase in breast cancer recurrence, while basic science studies continue to show in vitro and in vivo experiments that there is a potential adverse effect on adipose-derived stem cells and breast cancer cells. So what are the limitations? Why are we finding these differences? The concentration of adipose-derived stem cells used in all of these basic science studies compared to what is clinically grafted is significantly higher. The concentration of stem cells used in these in vitro and in vivo projects are 3, 4, and even sometimes 50 times magnitude greater than what's clinically grafted. The studies lack standardization. There's no standard in the harvest method. There's no standard in the surgical technique. There's no perspective or few perspective in randomized trials. Most of the patients were followed up for less than 3 years. There's inadequate follow-up. And banked and mortalized breast cancer cell lines are not representative of the average clinical patient that we see. These banked lines are designed to be hardy, reliable, and reproducible and wreckable lines. They're more durable, they're more mutated, and they're more aggressive. This is not what we see in our clinical practice. So maybe these are some of the reasons that we're getting a little bit of a difference. So now it's our turn to contribute to the scientific community. What do we want to do? We wanted to create a more clinically accurate model. So we were going to develop a co-culture model where we harvested adipose-derived stem cells and breast cancer cells from the same patient. We're going to eliminate the bias of the immortalized banked breast cancer cell line. We also wanted to reduce the limitations of the current data. So we wanted to study the effects of fat graft versus enriched fat graft. We're not going to use a concentrated high volume of stem cells, but we're going to do a co-injection model that specifically looks at a clinically relevant fat graft. We're going to do an autologous fat graft to nude mice that represents the same concentration of stem cells that's used in clinical practice. And we're going to see if our data is different. We wanted to answer the question, is oncoplastic fat grafting to the breast safe? And we're going to do this with in vitro and in vivo murine models. So our pilot study, we wanted to investigate the in vitro response of adipose-derived stem cells to breast cancer cells in a co-culture model. And we harvested these tissue from the same patient. What we did was we harvested breast and adipose tissue from a patient that underwent oncologic surgery here at UC Davis. After pathology was done, the bioprocessor gave it to us, and we did a combination of enzymatic digestion and explant culture to grow cell lines. Here's light microscopy showing bundles of breast cancer cells, and again, a CD24, an epithelial marker tagged with a red fluorescent protein, showing staining of breast cancer cells in our specimen. We then wanted to do flow cytometric characterization. We created an isotype control and an unstained control to show that there was no non-specific binding. We then looked at CD44, 73, 90, and 105, well-known markers of human adipose-derived stem cells. And we characterized that there was strong expressivity in all 4 markers characterizing our human adipose-derived stem cell line. We then did a negative cocktail to make sure that there was no bias or contamination. In order to isolate our breast cancer cells, we positively selected for CD24, a well-known epithelial marker to breast cancer, and negatively selected out CD90, a well-known marker of human adipose-derived stem cells, and we're left with the orange population here in the left upper corner, which was a distinct homogeneous population of breast cancer cells. Once we took these cells and expanded them and we plated them in a co-culture cell migration assay, we found a 10-fold increase in cell migration, breast cancer cell migration, when co-cultured with adipose-derived stem cells when compared to those that were just cultured with media and PBS. So this shows that even in the same patient, you're still getting these adverse effects of adipose-derived stem cells on breast cancer cells. Conclusions. We successfully characterized and expanded breast and adipose-derived stem cells from a single patient, and we showed that the adipose-derived stem cells increase migration potential of breast cancer cells. So why is there a difference in the clinical data and the basic science data? One theory is that when we do these in vitro studies, we are providing a nutrient-rich media, which is ideal for the proliferation of these adipose-derived stem cells, giving them the optimal environment to really express their effects on the breast cancer cells. But when you do fat grafting, you're taking the fat tissue that has some stem cells and moving it into another area where it basically relies on neovascularization in order to gain these nutrients. And so the stem cells may not have the same potential to express their ultimate malignant gene expression or upregulation of these genes in the clinical model. So we wanted to kind of study this. So what are our limitations on this study? One, it's difficult to isolate breast cancer cells from donor patients. With new screening technologies and finding cancers at earlier stage, oftentimes we were left with sub-centimeter specimens. These specimens, after pathology was finished with them, I was looking at the magnitude of about 99.5% stem cells to 0.5% breast cancer cells. It's extremely difficult to isolate and expand these cells. The adipose-derived stem cells in the in vitro model, when we try to do our culture expansions, will just outcompete and basically kill the breast cancer cells. And then we were left with only a small sample size. Because of 11 patients, I was only adequately able to isolate and expand a single breast cancer line from a single patient. So we wanted to create a spin-off study. Does the concentration of adipose-derived stem cells in fat graft affect breast cancer cells and tumor growth? So we wanted to look at a control versus fat graft, unmanipulated, versus a fat graft that was enriched with adipose-derived stem cells. In addition, we wanted to know, does this in vitro environment actually stimulate the adipose-derived stem cell that is not found in the clinical model, which this model would also help. We did have to resort to using the immortalized breast cancer cell line because it just wasn't feasible to create enough patients that we could isolate our breast cancer cell lines. And so we created an in vitro and in vivo arms. So again, we harvested tissue from lipoaspirate, underwent collagenase digestion, and then we looked and isolated our human adipose-derived stem cells, and we had our red fluorescent protein labeled breast cancer cell line. And we did the same co-culture in vitro assay. In all 3 lines, there was increased migration. However, only 2 of our lines showed that there was a statistically significant increase in cell migration when you co-culture adipose-derived stem cells in the presence of breast cancer cells. Next, we had to do our in vivo step. We harvested adipose tissue from lipoaspirate. We underwent collagenase digestion, and then fat graft under the Coleman technique, which consisted of a 3000 G centrifuge for 3 minutes. That allows you to pour off the plasma portion, and you're left with strictly the fat graft. We labeled our human adipose-derived stem cells with DIO, and again, our breast cancer cells were labeled with RFP so we could identify them easily. We then did our in vivo injections. The fat graft was injected with 18-gauge needles, while the cell suspensions were injected with 25-gauge needles. We wanted to standardize, so we used 8 × 10⁵ breast cancer cells for all lines. We also wanted to standardize our volume. So when we were using the stem cells, we also used 1.8 times 10 to the 5, and we had an injection volume that totaled 300 microliters. So if you were just a cell suspension, which would be groups 1 and 2, then we used 300. For the fat graft groups, we used 150 cell suspension with our breast cancer cells and or breast cancer and adipose-derived stem cells, and 150 microliters of fat graft itself to standardize the volume. We then tracked every 2 days with calibrated measurements the primary tumor growth and euthanized the animals at day 15 after 2 weeks and measured their primary tumor size, and then did cross-sectional slides to look for breast cancer presence, as well as we looked at organs for any metastatic potential. Here we included the fat graft volume. We then sectioned our specimens and looked at the percent of volume of fat in the tumors and used J-imaging software to subtract the amount of fat graft from groups 3 and 4 to see if actually the fat itself was causing there to be a statistically significant increase in the tumor size. And when we did this data a second time after we subtracted the fat graft volume, we had exactly the same statistical significance. Nothing changed. So that basically says that the amount of fat that we injected was negligible and did not affect tumor size based on the incorporation of the fat within the tumor. We also looked for the presence of adipose-derived stem cells at 2 weeks. We're looking for the DIO staining, and we didn't see any. And this kind of supports the theory that in the clinical model, the adipose-derived stem cells don't survive because they do rely on neovascularization, and they don't have that nutrient-rich media that you find in the in vitro model, which could explain part of the discordance. We also measured von Willebrand factor as a measure to look at vascular density, and we found that only the group that underwent fat grafting with human adipose-derived stem cells enriched, as well as breast cancer, had a significant increase in von Willebrand factor, which is something that we used as a potential for angiogenesis. And this makes sense because if you create the fat graft that has some of that natural environment, and then you inject the concentrated stem cells in it, they have a better chance to survive than if it were just a non-concentrated normal amount that we use in our clinical grafting. We also sectioned the liver as well as the lung of 3 randomly selected animals, and we took a total of 5 sections, and there were no metastatic disease in any of our animals at 2 weeks. We also did RFP staining looking for any micrometastases that we may have missed grossly. You can see in our control we have good red staining, but in none of our specimens that we pick up any of our RFP labeled cancer cells. Again, confirming no metastases. When we did our initial pilot study, we planned to keep the animals alive for 4 weeks. However, they had to be euthanized at 3 weeks due to the erosion of the tumor through the skin. Due to ethical issues, we had to end the study at 15 days. However, when we did look at staining of those animals, there was noted metastatic disease, which makes sense because the tumor burden was so large that it basically killed the animal itself before we reached our 4-week mark. And there was a statistically significant increase in the number of metastases in group 4, which is the group that had enriched fat graft. They had isolated adipose-derived stem cells co-injected with breast cancer in addition to fat graft. So this could suggest there's a time-dependent model associated with the effects of adipose-derived stem cells on breast cancer cells. So in our discussion here, the in vitro versus in vivo discrepancy. Do injected mesenchymal stem cells do not survive? Again, I've discussed the nutrient-rich media versus neovascularization. It's possible that the clinical data that we get is because the effect of these stem cells is not the same in the clinic as it is in the clinical application as it is in the lab, in the basic science studies. Immortalized breast cancer cells are not an accurate representation of our clinical application. They do provide reliable and replicable source of xenograft models, which is good for producing data, but it's not what we see. These are more aggressive tumors than we typically see in our clinical practice, so we need to keep that into consideration when drawing conclusions from our research. In addition, there's a highly complex in vivo environment. Adipose tissue provides a peritumoral environment, and it's the adipose stem cell rich fat graft preserves this more natural environment. Here's a busy slide that basically breaks down the relationship between fat tissue, the concentrated stem cells, and their interaction with the breast cancer cell and how they can lead to proliferation, anti-apoptosis, and survival of the breast cancer cell. In conclusion, human adipose-derived stem cells increase the migration potential of breast cancer cells in vitro. Adipose-derived stem cells enriched fat grafts increase the growth of breast cancer xenografts in an in vivo model. However, unprocessed fat graft, which represents what we use in the clinical practice, does not increase breast cancer growth significantly. Final thoughts. In vitro studies provide an environment suited for ASC proliferation, and this could cause us to have a difference in data. Clinical studies have failed to show an increase in breast cancer recurrence following oncoplastic fat grafting. Lipoaspirate fat grafts do not significantly increase tumor growth in a murine model. However, enriching lipoaspirate with adipose-derived stem cells will increase tumor burden. We recommend avoiding oncoplastic grafting of enriched lipoaspirate, but unprocessed fat graft is safe. I wanted to give a special thanks to my wife, who's kind of supported me through this journey and will continue to support me despite the long hours that I'm away, so that I can pursue my passions of both clinical and basic science. I also want to thank Dr. Sahar for creating an opportunity in the lab, Dr. Hakan Orbe, who allows these projects to continue to go as I am tending to my clinical duties, Dr. Hinchcliffe, who has greatly contributed to the amount of data that we've been able to get for these, and last but not least, Dr. Farmer, who's not only institutionally supported us, but when we had funding issues, was able to provide us with additional funding so our data could continue to be collected. And at this time, I'll take any questions.
Nice job, Heath.
Thank you.
Dr. Farmer got called out suddenly, so he asked me just to conclude.
Enjoyed that quite a bit. Now, you showed studies from Petit or Petit. I don't know how it's pronounced either, but it suggested that the higher local recurrence in those cohorts were from the intraepithelial breast cancer. So those are inside
Right.
cancers, somehow causing more local recurrences than the invasive breast cancers. That's a little counterintuitive, but I was thinking about, well, what are the differences? Maybe we know that the intraepithelial in situ breast cancers are growing successfully in a relatively oxygen deficient environment, and maybe when they're grafted, there's that little interval when there's not enough neovascularity to provide oxygen. Maybe that makes sense. Maybe that's why those cells proliferate. I don't know, but that was something very interesting. I'm sure you thought of it too.
Yeah, I have thought of it. And the interesting thing is there's no literature that has actually tried to explain it. It's just this isolated phenomenon that was found, and it hasn't been reproduced by other people, which is the interesting thing. I feel it's necessary to include that. And whenever I give these talks at conferences, one of the things I always end my talk with is that it's really important that when you offer fat grafting, autologous fat grafting to the patient, either in the post-oncologic setting or in a patient that has a family history of breast cancer, but they just want to use it for cosmetic augmentation, that when you do your informed consent, you tell them that there is a study out there that shows a potential increase in recurrence following this. It hasn't been replicated. We don't think that it's necessarily a direct correlation, but it's certainly something that needs to be included in your informed consent discussion with the patient. It would be a real tragedy to, do a fat graft in a young woman, say 25 years old, and then 10 years later her come back with a massive breast cancer, and then some data come out later to say this indeed isn't safe, and then her be kind of looking at you and say, why didn't you tell me that there was a study out there that showed that there was a risk? So I think that it's important to include that in the informed consent, but the overall lack of data as a whole to support increased recurrence following fat grafting still seems to say that fat grafting is safe, and it is still widespread practice for many surgeons throughout America and even France and Germany and Europe. So,
Questions on that side?
I apologize up front for dumbing down the quality of these rounds. They're brilliant and very, very well done. The first thing is, you mentioned your interest in oncoplastic surgery. From a non-plastic surgeon, I see oncoplastic surgery as the goal of oncoplastic surgery, to restore appearance of the breast and the patient's well-being. That's the first thing. And if so, is there anything that shows that fat grafting does this in terms of have you used the breast, or are you going to use the breast Q, for example, in assessing these results in comparison to other mechanisms of restoring breast cavities? That's question number one. And the second one is involved with the research you've done, which is fascinating on fat grafting. I'm a simple country guy, but as far as I know, stem cells can't survive without a healthy matrix. Mina Bissell in 2009 from Berkeley demonstrated a dynamic reciprocity between the cells in the matrix, specifically with breast cancer cells, and noted that when you put essentially breast cancer cells put it on a normal matrix, the phenotype the breast cells return to normal. And we know that changes in cell matrix interactions are critical to the development and the progress of cancer cells, and this is being seen with increasing right across the board. We're seeing that there's a focus on that interaction. Have you looked in any of your studies at the interaction and the effect of the matrix on your background?
We haven't specifically looked at that, but I think that's something that we could certainly look at going forward. I think that's an interesting concept. But to answer your first question, I haven't pulled any personal studies that have looked at just tissue relocation or remodeling during the initial phase, which is basically what they call level 1 or level 2 basic oncoplastic surgery, marking the patient in a specific way, making your incision in a specific way, and locally transferring tissue to minimize the deformity that the patient's going to experience, as opposed to the more complex level 2, 3, and 4, which is taking tissue from other areas or doing flaps and things of that nature. The specific original definition of oncoplastic surgery was related to what can you do during the initial operation to minimize the cosmetic deformity without sacrificing any of the oncologic resection. I've kind of expanded the definition a little bit in my research to kind of say, well, sometimes these things are done on a delayed basis, and so it doesn't meet the true definition of oncoplastic surgery, but I feel like it falls into the same genre. So I like to include it all together. As far as your second question goes, I think that's something that we could definitely investigate and would certainly contribute to the validity of our studies. So it's something I'll look into.
So most of the cosmetic and reconstructive applications for fat grafting out there claim that stem cells, adipose-derived stem cells, are going to be part of the reason why all of a sudden scars are going to be better, or faces are going to look younger, and things are going to be repaired. Your studies, and the ones that you presented, seem to show that fat grafting to the breast is overall bad, but we're kind of hoping that if we use it just with regular fat, that there aren't going to be any stem cells in there, and therefore it won't be quite as bad. Or at least we haven't been able to measure clinical negative impact. With all that in mind, if your lovely young wife were to ever need this procedure, would you, in today's day, advise her to undergo fat grafting or oncoplastic reconstruction?
I would.
You would?
Yeah. Dr. Pooh?
Just there, we're just gonna.
Okay, let me expand. The reason I would is because the clinical data is definitely the more powerful data, in my opinion. We haven't shown an increased risk. We're continuing to have more and more data published, longer follow-up. Some of these studies that were initially published with 1, 2, or even 3-year follow-ups are having additional studies or follow-up studies published with even further follow-up. There still isn't a clinical identity that says it's going to increase your risk, and the benefits of fat grafting and the outcomes that you get, I think, far outweigh any potential risk that we have right now. And I do believe that autologous fat grafting is the future of plastic surgery, and I just the benefits that it offers are widespread, and we could literally talk for weeks about it. And so and my personal opinion is that we're going to prove that it doesn't correlate to increased recurrence, that it will continue to show in the in vitro settings that there are some potential adverse effects, but for reasons that have yet to be determined but will be found probably in the next 10 years, it's not correlating clinically into the clinical patient.
There's more questions, but when fat grafting was initially banned, was it banned because of necrosis that occurred, or was it banned because of increased recurrence of cancer?
The original ban was because of necrosis and their concern that it would interfere with the ability to detect breast cancer recurrence and its ability to affect the imaging at that time.
So what's changed in the instance of recurrence? Is the tissue handling? Is it the volume? What's made that no longer the reason for not using it? So basically when they lifted the ban, they still said that we don't know if it's 100% safe, but we know that there are good benefits to it. But our current modalities of imaging now are so good that we will still be able to pick up breast cancer recurrence in an early stage, that in the clinical data have yet to show that there's an increase based on the baseline of recurrence. So at this point, our surveillance is good enough that we're not gonna say don't do it, but we will say we're not telling you that this is a scotch-free procedure. Do it at your own risk. They did exercise a caution, but they said that they would support it.
Great talk.
Thanks.
So I just wanted to kind of jump on to Dr. Medina's question, because I agree with you that fat grafting should be offered depending on the surgeon's risk tolerance, to do the informed consent for the possible increased risk for breast cancer. But one thing that you alluded to that's coming out a lot more is enriched fat grafts and injecting enriched fat grafts. And given your data, would you support doing an enriched fat graft for a patient?
Right now, no. No. And that's like when we present this data at CSPS, kind of one of the concluding slides is going to say that based on our current data, we would support Coleman technique, but not Yoshimura? Yeah, not his study of taking the stromal vascular fraction and adding it to the graft and injecting it, because that's going to give you a much higher concentration of stem cells. So we would advise against doing that until more data can be obtained.
Enjoy your lecture. I want to make one comment, two simple questions. One is fat graft is indeed revolutionized the outcome of breast popular technique, even in North America. And so my question is, for a cancer patient, a non-cancer patient, how would fat grafting improve the outcome of this reduction? Based on your study, what should we tell the patient? Second question is fat graft become a technique of primary breast augmentation. It's very popular outside the U.S. Actually, in the Asian market, there's a significant drop of the cells of the breast implant because of the fat graft. And for a young patient without a history of family history of cancer, what should we tell the patient that's safe to do fat graft?
So I'll answer your second question first. The second question, for strictly cosmetic augmentation in a young woman that has no family history of breast cancer, I would tell the patient that, I would still offer fat grafting to the breast to them, but I would explain to the patient that in a laboratory model, there has been adverse effects that show that breast cancer can be ramped up. So if you do have some residual breast cancer cells in your breast that aren't identified, or you have the potential for your adipose tissue to transform into breast cancer, and we do fat graft in these, and the stem cells are there is a risk that it could cause this cancer to grow faster or become more aggressive. However, we don't have clinical data to prove this. In a patient that has a known history, specifically like a mother or a sister that had breast cancer, I would push them towards an implant-based augmentation over fat grafting until we got more data. Just because the risk of them having a breast cancer is so much higher. It's kind of like, don't poke a skunk. We don't know for sure the right answer, but I think that in that particular situation, until we can generate more data, I would offer them another option, which would be the implant-based augmentation. To answer your first question, what would I tell the patient? Basically, what I would tell the patient is, if you're going to undergo oncoplastic fat grafting, and you want to do it in the immediate setting, it's paramount that we make sure that we have negative margins. There has been some suggestions about potentially doing like intraoperative frozens prior to doing the fat grafting to confirm that you don't have a positive margin, which would be more indicative that you removed all the cancer. Or you could do it in a delayed fashion once you're able to get pathology back. If the patient needs to undergo hormonal therapy and or radiation therapy, you could kind of use it as an adjuvant while they're getting the additional therapies. So that's what I would tell them.
Well, with that, I want to congratulate Heath once again for an outstandingly productive time and for very informative and enlightening backgrounds. Thanks, Heath.
Thank you.